Well, I feel like saying evening, everyone, because it's 7 o'clock at night here in Brisbane, Queensland, Australia, but I know it's mostly 10 o'clock, I think, where you are in the morning. So I was asked by the BOHS to give a presentation to you about what's happening in occupational hygiene in Australia. So I've prepared this presentation as a little bit of a whirlwind tour of different topics to do with occupational hygiene from an Australian perspective and an Australian context. As a background to myself, I'm currently the president of the Australian Institute of Occupational Hygiene for 2026. Loving every minute of it. It's challenging, but I am actually really enjoying the challenge of being the president. I'm a bit over halfway through, so I hand over to Dr. Ross DiColetto, who's my president-elect, who'll take over at our conference in December. In my day job, who's obviously being president of the Australian Institute of Occupational Hygiene, is a volunteer role. So my paid day job, I'm an associate professor at the University of Queensland, and I am the director of a Masters of Occupational Hygiene and a dual program with the Masters of Occupational Health and Safety Science at UQ. So that's a little bit about myself. I may have met some of you. I recently came over to Glasgow and attended your British conference, and I had a lovely time. Thoroughly enjoyed it. And I think some of the topics I'll discuss tonight will be very relevant, given that they were also topics at your conference. So I think that the topics that we'll cover are relevant not just to Australia, but a lot of countries around the world. So without further ado, what are some of the things that we'll be talking about this morning in your webinar? Well, I'll very briefly touch on a bit of an Australian context for you, for those of you who perhaps haven't had the pleasure of coming and visiting us all the way over here in Australia. I'll move on then to discuss silica and the engineered stone crisis in Australia, which has been a big issue over the last 5 to 10 years at least. I'll discuss our review in Australia that we've had that began in 2018 of our workplace exposure standards, which has been a significant shift in our exposure standards in Australia. We'll briefly discuss diesel particulate matter, welding fume, and disease surveillance, and I'll touch on psychosocial hazards, biological hazards, and climate risks, and a brief look into what I think might be coming in the next few years in occupational hygiene in Australia. Most of what I'll present today are my personal reflections on where things are at in occupational hygiene in Australia, or it's based on government reports, things that we've been doing within the AOH, etc. So starting with some context, for those of you who haven't had the pleasure of coming over to Australia, we are a very vast, large continent, 7.69 million square kilometres. We do have a fairly small population for a country that size. We have 28 million people in terms of a total population, or roughly 28 million. Of those, 14.7 million are considered as the working population of Australia. So if we compare that to the UK, I did a quick Google search and it tells me that the UK has over 241,000 square kilometre land area. And for that much smaller relatively land area, you've got a lot more people, 69.9 million population, and more than double our working population of 33.5 million. So just a little bit of context. And that beautiful picture of the red desert is what most of the middle of Australia looks like. And the majority of our population live in our coastal areas, and particularly on the eastern coast of Australia. In terms of industries that employ occupational hygienists in Australia, well, it's mainly heavy industry sectors, so mining and quarrying, construction, manufacturing, heavy transport, some agriculture, and of course a lot of our AOH members are consultants as well or work for the government. So we are a relatively small, tightly networked profession, and the AIOH, or Australian Institute of Occupational Hygiene, is the peak body for professional occupational hygienists in Australia. In terms of regulating occupational health and safety more generally, we have, much to my dismay, and I would prefer it not to be this way, but it's regulated at a state and territory level. So unlike the UK, where you have the HSE, a central body, we have a different regulator in each state and territory in Australia. It's just the way that it was developed. We do, however, have a model Work Health and Safety Act and regulations that has been adopted by most of our states and territories, apart from Victoria. And that model legislation has been kept relatively the same, with some changes in each state and territory. We do have a national body called Safe Work Australia, and they provide guidance. They're not a regulator. They provide model laws that states and territories can adopt. So that's a bit of a rough explanation of the context in terms of occupational health and safety and occupational hygiene in Australia. At the British Conference in June, a few weeks ago, I did give a short presentation about the AOH, and I thought I would provide one quick snapshot for you in this presentation. So for those of you who heard it at the conference, apologies. Just to give you an overview of ourselves as a professional body in Australia. So the AOH was established in 1980. We've actually just ticked over 1,700 members. We have, of those, 242 are certified occupational hygienists. We have 778 full members, 534 associate members, 95 fellows, 92 retired members, and 48 full-time student members. One thing that I'm really proud of and has thoroughly enjoyed as the AOH president this year is the sheer number of people within our profession that put their hand up and volunteer and get involved in the work of the AOH. And we have around about 165 active volunteers that power our committees and our working groups. And I'll talk about some of the things that they're doing as we go through the presentation today. So we are a growing and diversified profession. We do have over 35% of our members are females. Now I say over because not all members provide their gender details, but roughly 35 to 40% of our members are female, and this is rising. We do have student numbers increasing as well, which is good to see. Probably not at a fast enough rate. We do need to encourage more young people to join the profession in Australia, and we will have a significant number of people moving towards retirement in the next 5 to 10 years or so. So it is something on my mind currently as the president, and also in my role as an academic, that we need to encourage more young people to join the profession. We do have what we call chapters in our states that get together locally to discuss hygiene issues and socially meet up with each other. Our largest chapters, and obviously our biggest states, New South Wales and Queensland, and WA, which is a large mining state in Australia. If we think about our 1,700 odd members, that's about one AOH member for every 8,700 Australian workers, or roughly 11.5 AOH members per 100,000 workers. That doesn't sound too bad, but if we look at our certified members, with only 242 certified members, that would be a lot less certified people to working population. And we have 30 members that represent the AOH externally on national and international bodies. So moving more now into the main part of the presentation, I wanted to talk about two key events that have happened in the last 5 to 10 years in Australia. And firstly, we start with black lung, or coal miners' pneumoconiosis. So this is a disease that in Australia, being a large mining country and coal mining country, that we thought we had well under control. And there hadn't been reports of coal workers' pneumoconiosis for about 30 years. And so we were fairly confident in the idea that we were managing exposure to coal dust well in Australia. That was until 2015 when we started to see what we call the re-emergence of black lung or coal workers pneumoconiosis in Australia. And we had 6 to 11 cases confirmed by mid-2016, and there's been a growing number of cases of not only coal workers pneumoconiosis, but particularly COPD in the mining population in Australia since that time. So as a result of this resurgence of black lung disease in Australia, the Australian government and state governments held 2 inquiries. So we had a Senate Select Committee inquiry into black lung, and we had a Queensland parliamentary inquiry into black lung. And those 2 inquiries found that we had an overconfidence that we were managing the disease and that the disease had potentially been eliminated in Australia. Weak disease surveillance systems became evident with inconsistent radiological interpretation. So there were lots of issues with how X-rays were being taken, how they were being interpreted, how this information was being managed by regulators. So there's been a very large overhaul of this system in Australia since 2015, and there was an insufficient focus on prevention over compliance. So a quote from one of these inquiries said that the absence of detected disease is not evidence of absence of the disease, obviously. And many of the national systems that Australia has now got in place, including our National Occupational Respiratory Disease Register, sort of can trace back its beginnings to this first re-emergence of black lung disease in 2015. So moving then on to the engineered stone silicosis crisis in Australia. Now, obviously, this is not something that's just happening in Australia. Engineered stone is used throughout the world, including the UK. And I know, having been to your conference, that you are battling with this as an issue yourselves in the UK. So this first started to come to the regulators' attention, occupational physicians' attention, media attention in the mid, 2015, around that kind of time period. And I've got a timeline coming up soon with more details. Victoria was one of the states that thoroughly investigated this when it first emerged, and there's been a paper published on the work that they did. There's a reference at the bottom of the screen there for you, but they found that most cases of silicosis were detected through active government screening rather than routine clinical presentations, someone being unwell and presenting to the doctor. So 536 Victorian silicosis compensation claims were made between 1991 and 2022, but 90% of those claims were lodged between 2015 and 2022, and 27 times increase in claims incident versus the preceding 8 years. 97% of registry cases were from stone benchtop industry workers. And in 2019, we saw the death of the first worker from silicosis. He was a young man in his 30s, and that's an image there of a report on his death from the ABC media. And this silicosis crisis is probably the most consequential Australian occupational hygiene issue over the past 5 to 10 years. If we turn nationally, it is difficult to get statistics on the number of silicosis cases. Hence, the government has established a National Occupational Respiratory Disease Register that began operation in May 2024. But looking back previous to the establishment of that register, there's estimated to be 600 or so stone benchtop workers who were diagnosed nationally by the time period of sort of 2022, 2023. And about 18% of those cases are workers with complicated silicosis or progressive massive fibrosis. In New South Wales, there were 516 silicosis cases reported since 2017 and 36 deaths. So that's in one state alone. 380 silicosis cases recorded in Queensland. It operated its own register from 2019 onwards, which has now been folded into the National Register. And researchers have estimated that Australia should expect somewhere between 83,000 and 100,000 future silicosis cases projected based on the rates we saw as a result of this initial screening, and over 10,000 lung cancer cases. So looking at the timeline here, we can see that engineered stone was introduced into Australia in the early 2000s, as it probably was in many other countries around the world. We had our first case of silicosis diagnosed in Australia in 2015. In 2018, some occupational physicians in Queensland began to diagnose silicosis and raised an alarm of an epidemic of silicosis in Queensland. In 2019, a dust disease task force was established. In 2021, the Dust Disease Task Force final report was produced, and this report recommended that if the controls that were required to get respirable crystalline silica levels down to reasonable levels were not implemented well and not working effectively, then Australia should move towards a ban. So their recommendation was that if these controls aren't working post-2023, that Australia should proceed to a ban. There was a shift in industry towards new products from around about mid-2023 onwards, and we saw that IKEA and Bunnings stopped selling these products and other alternative products started to appear in the market. By mid-2024, a ban was enacted. So Safe Work Australia, that national body, recommended a ban. It was accepted nationally and the ban came into effect mid-2024. And we are obviously moving on from there, post a ban on high silica content engineered stone products in Australia. Deb Glass, who some of you might know, she's an academic here in Australia but comes from the UK. She's published a paper in the British Hygiene Journal on what happened in Australia, and this is a timeline figure from her paper. So which, the previous slide gave us just the basic timeline, but now we see the timeline mapped against the number of artificial stone silicosis cases reported in Australia. And so you can see that real spike and increasing trajectory in cases post about 2016. So how did we end up with a ban in Australia? So Australia is the first country around the world to ban high silica content engineered stone products. Well, a paper was published by a number of Australian authors, including Kate Cole, who some of you may know, a previous AOH president, that applied what's called the Kingdom's Multiple Streams framework. It's a public health policy framework to analyse what it was that happened from the problem of the silicosis crisis, the policy arena, and the politics, and that these three things came together. I suppose you could think of it like James Reason's Swiss cheese model. All the holes in the cheese lined up. We had a perfect window of opportunity in which the government felt confident that it could enact a ban on this product. So in a little bit more detail, the problem, of course, which is similar to the problem all around the world, is that it's a public health crisis affecting young workers who work with this product, manufacturing it, altering it, installing it, etc. There are clear, irrefutable evidence linked to the industry that workers in this industry exposed to this product are being diagnosed with silicosis. There was intense media scrutiny around this in Australia, and you saw the image before of the first worker who sadly died in 2019 of silicosis. So there was a lot of coverage on this topic in news reports, on the TV, newspaper, etc. In terms of the policy area, multiple options were analysed including awareness campaigns, licensing in Victoria, and many things were tried over about a 9-year period following the first diagnosis in 2015 to improve control of this hazard in these small businesses. There was strong stakeholder engagement, and the Dust Disease Task Force obviously also coming forward and recommending a ban. In terms of the politics, there was sustained advocacy from union groups, professional associations such as ours, and the Thoracic Society of Australia and New Zealand, academics, and the media. And there was strong synergy between actors and continuous pressure on government. It's also a relatively small industry in Australia, worth about 160 million. And it meant that there was low political risk to introduce a ban. And in fact, we have seen that there are alternatives in the market that are being used in Australia with the ban. So the idea was, well, what will people install if there's no engineered stone? But very quickly, once the ban or the concept of a ban came to light, we saw alternative, lower or no silica content products appearing in the marketplace. What did hygienists see on the ground before the ban came into place? Well, a paper was published by some Australian hygienists who surveyed 105 AOH members, and they were relatively senior members of the AOH who had been involved in collecting data on silica exposure, not just in the stone benchtop industry, but tunnelling, construction, other industries. So this survey found that 71% of hygienists were concerned about RCS overexposures based on their own monitoring experience, that 66% said engineered stone workers seldom or never use real-time monitoring. Employer awareness of RCS risk was low in engineered stone industry and lower than construction and mining and other larger sectors. The top barriers to implementing controls were a lack of management commitment, lack of financial resources, and low compliance with existing rules. And just some images here that were taken before the ban show you the sort of conditions in these small businesses where engineered stone was being prepared for installation, and then other images of dust on all kinds of surfaces. So Australia has not just banned this engineered stone, high silica content engineered stone product, but we have also taken other action in terms of silica exposure more generally. So since September 2024, crystalline silica substance regulations have been enacted around Australia. So a crystalline silica substance is a substance considered to contain greater than 1% crystalline silica weight for weight. Combining the existence of that product with processing of that product means that employers have to complete a risk assessment of exposure if they're working with crystalline silica substances that contain more than 1% crystalline silica. If the risk is high or deemed to be high as per the regulations, then a silica risk control plan is required. That plan has to be made available and communicated to relevant parties. There's a duty to train workers. There's requirements for air monitoring and health monitoring. So not only have we banned these high silica content engineered stone products, but we've also looked to manage silica exposure wherever that may occur in construction, tunnelling, mining, etc. And not just these engineered stone products, but any substance containing more than 1% silica. Employers must also report all exceedances of the workplace exposure standard to the Work Health and Safety Regulator. The Silica National Strategic Plan aims to prevent new cases of accelerated silicosis by 2033, which would be wonderful if that was the case. So lessons for other jurisdictions. The idea that these high silica content products can be used safely is questionable. And it was not well demonstrated that this could actually take place across small shops, small industries in Australia. Enforcement is difficult because we've got 100 plus small fabrication shops, and in order to make ensure these controls are effective, we need to send inspectors out there to ensure compliance with regulations. Licensing and incremental tightening take too long. They might work, but they're slow, and in the meantime, people can be being exposed. Prohibition or banning of the product simplifies enforcement, and it drives safer product substitution without getting rid of or eliminating the industry. So I suppose in summary, in Australia, we have found that the ban has been successful in terms of reducing exposures. So moving on from silica now, this table here provides a summary of some changes to our current workplace exposure standards that have occurred alongside and as a result of these two big crises that have occurred in occupational hygiene in Australia. So firstly, I mentioned the resurgence of coal workers' pneumoconiosis. And so the respirable coal dust exposure standard, which was previously a TWA of 3 milligrams per metre cubed, has been revised down to 1.5 in 2022. And you can see that respirable crystalline silica, which previously had a TWA of 0.1 milligrams per metre cubed, has been revised down to 0.05. There was a proposal to reduce that further down to 0.025, but we've recently found out that that's not been accepted by the ministers in the states and territories, and they've called for more investigation into that. And so we remain with an exposure standard of a TWA of 0.05. We saw the introduction of a reduced welding fume exposure standard, so total welding fume from 5 down to 1 milligrams per metre cubed in 2024 as a result of welding fume being the IARC changing the welding fume classification to a class 1 carcinogen. We also have the introduction of an aluminium welding fume exposure standard of 1 milligram per metre cubed. So moving on now to the comprehensive review that's occurred of Australia's workplace exposure standards. So this review began in 2018, and previous to this review, Australia's last review of its exposure standards was back in 2003. Arguably, this review was well overdue. A lot of our exposure standards were, in my opinion, outdated. They had been adopted from ACGIH exposure standard levels back in the 1990s and had not been comprehensively reviewed since then, basically. So this has been a massive undertaking for Australia and for Safe Work Australia to review all of our exposure standards and go through the public consultation processes, etc., that's been required to get to where we are. Where we are is that we are moving from having what's called workplace exposure standards to workplace exposure limits. Our limits are tied to legislation in our model legislation, which is adopted in most of our states and territories. So they are legislative limits that must be complied with. The new workplace exposure limits come into effect on the 1st talking. Maybe towards the end, she might be able to chat to you a little bit about the work she's been doing. So Safe Work Australia Sue's been assisting Safe Work Australia to develop some guidance material for occupational hygienists on how to apply the new workplace exposure limits. So as I said, this has been a significant revision of our exposure limits with a health-based focus on the limits. It's a modernisation of our approach to exposure limits. So key shifts include adoption of contemporary toxicology evidence, greater emphasis on respirable and inhalable aerosol fractions, a stronger protection against occupational cancers, greater recognition of respiratory sensitizers. So we've had major reductions in flour, dust, isocyanates, etc., which reflect a current understanding of occupational asthma. Introduction of limits for emerging contaminants. I wouldn't call DPM necessarily emerging, but we do now have an exposure limit for DPM, and a move away from having a set workplace exposure limit for non-threshold genotoxic carcinogens towards elimination and minimization instead. So in terms of a summary of the changes to our workplace exposure limits, 31 new chemicals are being added to the list, including diesel particulate matter. So we previously did not have an Australian exposure limit. Some of our mining states had state-based requirements for or limits or recommended guidance around DPM. Australia has decided to adopt 0.01 milligrams per metre cubed as measured as respirable elemental carbon. 33 non-threshold genotoxic carcinogens will lose their numeric limit, and the focus will be on elimination, substitution, or minimisation of exposure to these chemicals. 238 existing chemicals have had their values or names changed. So we've had 188 entries be decreased, 15 increased, and 34 renamed or regrouped. And we've had 6 chemicals removed outright because these chemicals are now prohibited in Australia under Australian law, such as DDT, dieldrin, and eldrin. So you can see in the blue table there some of the example reductions. For example, beryllium's TWA exposure limit is 100 times lower, sulfuric acid 10 times lower, sulfur dioxide 8 times lower, chlorpyrifos half of 50% reduction, as same with paraquat. What does all this mean for occupational hygiene in Australia? Well, it means a lot of work in monitoring exposures against new exposure limits, perhaps redesigning similar exposure groups. For those organisations or industries where extended shifts beyond 8 hours are normal, such as the mining, oil and gas, construction industries, obviously these new limits will need to be shift adjusted. There'll be a push towards improved control of these chemicals to get levels below the exposure standards. We also need to be considering mixtures and simultaneous exposures. Personally, I think it's an issue that we will now have no set numerical level for these non-threshold genotoxic carcinogens. And so an example is oh gosh, I just was working on an example today and I've lost it. But one of the projects I'm working on at the moment involves monitoring workers who are doing bomb disposal work and their exposure to explosives, and some of those energetic chemicals are considered to be non-threshold genotoxic carcinogens, and so their exposure standards are being removed, and we'll no longer have a number to work with in Australia in terms of monitoring exposure to these chemicals for those workers. In terms of welding fume in Australia has had an uptick in attention from hygienists, organisations, industry. Safe Work Australia has currently got a public consultation happening on how we regulate exposure to welding fume in Australia. I did mention that we saw a reduction from 5 milligrams per metre cube to 1 in 2024 as a result of IARC's reclassification. But generally speaking, there's been a push to look at better control for welding fume exposure, the use of on-torch extraction, correctly designed and maintained local exhaust ventilation, the use of robotics and remote welding, focusing on individual exposures to the components in welding fumes, such as chrome-6, nickel, manganese, etc., and improvements in respiratory protective programs and use of powered air purifying respirators. So, as I mentioned, the federal government, Safe Work Australia, has an open consultation that closed just the other day on the 12th of July. They were calling for public comments on how we currently regulate exposure to welding fume and the welding fume model code of practice that we have. They're wanting to look to be more specific in the wording in the legislation and provide specific requirements around managing welding fume and updating the code of practice. So the AOH's submission that we provided was in support of this concept, and some of the information in that submission is summarised here. So we have about 79,100 structural steel and welding trade workers nationally. They generally hold a vet sector level, so certificate 3 or 4 level of education. 94% of welding and fabrication businesses employ fewer than 20 people. So much like the engineered stone crisis, welders typically work in small businesses. And an Australian survey of small businesses generally, so not just those doing welding, but small businesses generally, found that 24% of small businesses report conducting air monitoring and 33% conducting health monitoring. So small business generally, whether it be exposure to silica, welding fume, or any other occupational hygiene hazard, is an area that needs attention. 34% of surveyed welders also reported that they used air-supplied PAPR welding helmets. So that's a small percentage of welders surveyed. So AOH's position was that we need to prioritise engineering controls. We need better attention on effective and well-maintained local exhaust ventilation that complies with the ISO standard 21904. We need to be applying the hierarchy of controls and ensuring we've got higher order controls, not just relying on respiratory protective equipment. We need good training and awareness, including pictograms. We need health surveillance for workers, and we need to focus on controlling exposures before we do monitoring, making sure that where controls are absent, that they're implemented as soon as possible, and monitoring is conducted as a follow-up afterwards. I mentioned that we now will have sorry, I'll just grab a sip of water. We now will have a national exposure limit from the 1st of December for diesel particulate matter, which is at 0.01 milligrams per metre cubed, or 10 micrograms, measured as a respirable elemental carbon. We have long had exposure standards, I mentioned, in mining for DPM or guidance values, but this is the first time that we will have a national level for diesel. We also need to start thinking too about what will replace diesel engines. So I don't know about the UK, but in Australia, we are seeing electrification of vehicles, particularly personal passenger style vehicles, but also in mining, we're seeing electrification of equipment. So what new hazards will that bring is also an important topic to consider. Asbestos. Australia was one of the first countries also to ban asbestos containing materials in 2003. But we were also one of the biggest users of asbestos per capita around the world. And so we have a lot of legacy asbestos containing materials, around about 6 million tonnes, it's estimated, of ageing asbestos containing material remain in buildings in Australia, and approximately 2 people are diagnosed with mesothelioma in Australia each day. So the Asbestos National Strategic Plan emphasises proactive identification, prioritised removal and safe disposal of asbestos. We have also seen over the last 5 or so years illegal importation of asbestos-containing materials into Australia. So we need to keep a close eye on that from a customs and workplace perspective. We've had public health concerns over asbestos in children's coloured playing sand, so contaminated coloured play sand in schools and daycare centres and people's homes, which has caused public outcry. We've seen asbestos containing wood chip materials that have caused public concern and outcries, and other contaminated land issues with asbestos. So asbestos continues to be a key topic in Australia, and it will be for a long time to come. One of my pet topics to talk about is Australia's lack of a comprehensive national occupational disease surveillance system. So unlike the UK, I think you call it the THOR scheme. Someone can correct me later, where you're considered to have a good system of disease surveillance with data available to the people who need it about occupational diseases. In Australia, we have a very fragmented system. We have some workers' compensation data, we have hospital data, we have general cancer registers, but up until recently, we really have had no overall systematic disease surveillance system. We still don't. We need to be moving towards that, and thankfully we are starting to do that with the introduction of the National Occupational Respiratory Disease Registry. So it stores diagnosed occupational respiratory disease data to support prevention. So it covers diagnoses from the 22nd of May 2024 onwards. And initially, the key prescribed condition is silicosis, but it also records other occupational respiratory diseases. We've also recently seen the creation of an Australian Centres for Disease Control, mainly as a result of the COVID pandemic. But this is promising, and I'm hoping that the introduction of an Australian Centres for Disease Control will mean that we are finally moving towards creating a comprehensive system for occupational disease surveillance in Australia. I'll very briefly mention psychosocial risk. We have seen a rapid increase in attention on the topic of psychosocial risk in Australia, and many of our states and territories have introduced specific regulations and codes of practice on the topic of psychosocial risk. So New South Wales introduced legislation in 2022, Tasmania 23, WA 22, etc. So around that sort of 2022, 2023 time period, most of our states and territories implemented regulations and codes of practice around managing psychosocial risks in the workplace. So naturally, that creates attention on this topic. It is a very important topic. I do want to stress that my personal opinion is that hygienists can assist in this area, but we are not the subject matter experts when it comes to psychosocial risk. We do bring hazard ID skills, exposure characterization skills, we have knowledge of the hierarchy of controls, and we could make a positive contribution to a multidisciplinary team. But we are not psychologists, and so I feel that we need to be a team member in helping to manage this issue. We also need to upskill ourselves on this topic for sure. It is definitely an occupational health hazard, and we do need to be able to contribute to managing it effectively in the workplace. But I believe that the specialists in this field are organisational psychologists. So in terms of our Australian stats, 12% of serious compensation claims 2023-2024 were for mental health conditions, about 17,600 mental health claims for the same time period. And plus 161% increase in mental health claims over a 10-year period, 5 times the median time lost for occupational injuries and diseases for a mental health condition. The COVID-19 pandemic, we all remember it. We wish we didn't have to remember it, but it happened. In a way, it was positive for our profession in that it raised awareness of indoor air quality issues, biological hazards, and the existence of a profession called occupational hygiene. Kate Cole, who was our president in 2022, she managed to get a spot in the media and was often interviewed and called an occupational hygienist, which meant that mainstream society has at least heard the term occupational hygiene. So it was good for, if there was anything good that came out of the COVID-19 pandemic, it was good for raising awareness of the existence of occupational hygienists in Australia. But it has also led to promoting an increased focus on managing biological hazards in the workplace and indoor air. Australia has seen some states holding inquiries into indoor air. We have seen the introduction of a code of practice a model code of practice in Australia for managing biological hazards, and the AOH is going to be surveying its members later this year around members' knowledge and understanding of indoor air quality issues and proficiency in managing indoor air quality in the workplace. AI gets a quick mention. I'm sure we're all playing around with AI in various ways. AI is being used by hygienists in Australia, as I'm sure it is by hygienists all around the world, for drafting and reviewing reports, literature searches, summarising technical guidance, cleaning and organising and visualising data, etc. We've seen an increased interest in AI and occupational hygiene in our conferences. So in 2024 and 2025, we had continuing education sessions, keynote speakers, and plenary sessions on the topic. And I think, as we all would, that AI is going to continue to play an important role in most professions, including occupational hygiene. And for me, the important message is that AI might be used to draft the words of a hygienist, but the hygienist must own those words and own that interpretation. Climate change and heat are core issues for Australia. I know in the UK it's summer over there, it's winter here, but it's summer over there, and I have heard you've been having some heat waves. We do see the impacts of increasing temperatures. We see more severe bushfires, which lead to bushfire smoke exposures. We see increasing in heat waves, etc. And this is going to continue to be an issue. One of Australia's experts on heat exposure is our current president-elect, Dr. Rosti Coletto, and he has recently updated the AOH's guidance material about managing heat stress and heat exposures in the workplace, and that's a guidance that's available from our website. It's an excellent resource if you're looking for a one-stop shop for some key guidance on heat exposure in the workplace. Real-time monitoring has been a key interest of hygienists in Australia, much like the rest of the world, I'm sure, for quite a few years now. The AOH is about to release a guidance document on the use of real-time monitoring for dusts. Sue, who I mentioned is on the line, has added some material to the Safe Work Australia guidance to interpretation and use of the new WELS around real-time monitoring, not just for dust, but gases and vapours, etc. as well. Basically, in Australia, we're using real-time monitors in a hybrid model where real-time instruments are used for awareness raising, spotting patterns, diagnosing control failures, but it's of course still being backed up by other validated sampling methods. And hopefully this is technology that's going to keep developing and keep being something that assists the hygienists and workers and organisations into the future. Combined exposures, very quickly. This is also a pet topic of mine. I'm very interested in how we as hygienists can better manage the real life situation of multiple exposures to various hazards in the workplace at the one time. We all know that workers don't get exposed to one hazard at a time, and we need to be better as hygienists at being able to manage and understand the risks of multiple exposures. We do have a new boom in Australia of critical minerals with the focus on decarbonisation. So Australia is a major global producer of lithium, rare earth, vanadium, etc. And so these are areas where, as a hygienist, we need to ensure we are applying our skills to keep workers safe into the future. So the next 5 to 10 years, I think in Australia, we'll continue to see a focus on occupational dust lung disease. We will see the implementation of the new wells, which come into effect at the end of this year. Hopefully, we'll see improvements in our disease surveillance systems. We'll continue to see a focus on climate change and heat exposures. We'll continue to see a focus on indoor air quality and management of indoor air. We'll hopefully see some advancements in exposure, direct reading instruments and exposure modeling. AI is going to come along and help us, I'm sure, with modernising how we manage our data, perhaps how we monitor, etc. And we will need to broaden our remit and be able to contribute as a team member on the management of hazards such as psychosocial risks. So wrapping up, 5 developments to remember that I've discussed that's occurred in Australia over the past 5 to 10 years is the re-emergence of coal workers' pneumoconiosis and the engineered stone prohibition, the transition from exposure standards to wells, the improvement of our disease surveillance system, and the expansion of occupational hygiene's remit into specialist areas such as psychosocial risks, biological hazards, and indoor air, and the issues that will come from the adjustments that we're all making around the world because of climate change and the transition to renewable energies. I thought I'd put in a cheeky ad for our conference that's coming up in the first week of December, and it's being hosted in my hometown, which is Brisbane, Queensland. We always have a wonderful time. It's a fantastic conference. We get over 600 delegates, over 80 trade booths. We have lots of fun at our dress-up night, which I'm sure you may have heard of, our 3M theme night and our conference dinner. And we have a fantastic scientific program. So if you like the idea of a trip to Australia and a visit to sunny Queensland, you might like to scan that QR code. Registrations are open for our conference. As I said, it's the end of November, first week of December. So thank you very much. Hopefully I've sparked your interest. I'm sure I've talked about topics that are also relevant in the UK, and we probably have a couple of minutes left for questions. So let me just get you all back on the screen.
Yeah, thank you very much for that, Kelly.
Lee.
Yeah, well, we do have some questions there. Like I said, we've got about 5 minutes. There's a few things here, and if you do ask a question and we don't get around to it, please do send it over or just pop it into this chat because I'll still see the chat even after the webinar's finished, and we can pop those over to Kelly for an answer and circulate those with the recording. So we had a couple of questions here from Trevor. So, is quartz used for work surfaces in Oz? If so, why was it not included in the ban?
So a good question. let me just read the rest of that. On the re-emergence of was the 3 milligrams being, oh yes. Um, the engineered stone products that contained a high percentage, we're talking sort of 90+% of crystalline silica, were what was included in the ban. I'm not sure what you mean by quartz. Do you mean natural stone products like marble, etc.? Maybe Trevor can unmute himself.
Yeah, Trevor, if you are still in the chat, feel free to unmute and have the conversation.
We haven't banned natural products like marble. It's only the high silica content engineered stone that was banned. So I don't know if that answers the question. We do still use natural products in benchtops, such as marble, which does contain silica, but it would be controlled under our silica regulation. So any product that contains more than, or any substance that contains more than 1% silica needs to be managed under strict regulations and codes of practice about how that's managed, including risk assessments, training, high-level controls, monitoring, etc. So not sure if that answers your question. On the re-emergence of black lung, was the 3 milligrams being complied with, or were the exposures more than that in practice? That's a good question, and I don't have the data in front of me. In states like Queensland, where I'm from, mines have to report their data to the regulator. So the regulator had that data. So I can only assume that there would have been some exceedances of the exposure standard as part of that reporting, which would have been investigated. But generally levels would have been below the 3 milligrams per meter cubed because in mining states like Queensland, companies had to provide their monitoring data to the regulator. What else?
And we've got one final question here. We've got a couple of minutes. So there's a question here by Alex Bianchi, if you can see that. It's quite there.
Where are we, Lee?
If you just go into the chat and it's the third message up. I can read it out if it's easier.
Yeah, because I'm just scrolling down the third message up. Yeah, could you read it out, Lee, while I'm looking for
Yeah,
it?
of course. He said, great talk for first off. In conversation with Dr. Brian Davis a few years ago now, he advised that Australia has solid industrial sponsorship pathways for MSc and PhD research in hygiene and
Yep.
sound interactive links between the fields of academic research, industry, and government, in effect, joined up programs. Mining industry exposure assessment was a key example of this. The UK is not comparable in that regard, and industry sponsorship via academia for OH research teams is a bit patchy. Is that still the case in Australia, and what could we learn from you to help us move forward?
Okay, well, that's a very good question. Look, I'm not sure exactly what Brian was referring to, but I know that we do have a scheme in Australia, particularly for coal mines, where the big coal miners had to contribute money to a research fund. And that research fund was used obviously to sponsor PhD students and fund academic research in the coal mining industry. So that's a good example of where it was working successfully, is that the companies were basically required to pay a levy towards this fund to fund research in coal mining. That's the only example I'm aware of where that happened and continues to happen. We still have that. Being an academic in a university in Australia, it isn't necessarily easy to get funding for OHS research. I would think that outside of mining, it's probably similar to your experience in the UK, that it is difficult to get funding from industry for PhD student research and other academic research. I mean, it still happens, but it's outside of mining, I think it's probably similar to what you would experience in the UK.
Well,
Okay.
we're at 11, but I think there's just a few more questions. I don't know if you're free. I know people will start to filter out, but I don't know if you're happy to stick around and
Yeah, that's
answer last
fine.
two. Yeah.
I've got nowhere else to be
Well,
right now. That's fine.
well, Trevor, I don't know if you found the unmute button on your new device. I don't know if you want a chance there just to.
Yes, I
I
did.
think.
Thank you.
Oh,
There we go.
fantastic. Go, Trevor.
Well, I was just concerned that here quartz is commonly advertised for kitchen work surfaces and things like that, and I don't see that it's different um, in from engineered stone.
Yeah, I'm not sure. I don't believe we have quartz bench tops here in Australia. We certainly have alternative engineered stone products that contain very low or no silica, well, no crystalline silica. They do contain, been told, amorphous silica. Whether these new engineered products are any safer than the previous ones is still a topic of scientific inquiry. And we have academics here in Australia at Adelaide University, my own university, and some universities in New South Wales that are still doing research on these new products and trying to understand, the resins in them, etc., and whether they still present a risk to health, even though they have very low silica content. So there's still a question mark over these new products. Quartz, I'm going to have to take that on notice because I don't believe that we have quartz bench tops here in Australia. We certainly have cement tops, wood, marble, laminate, and those types of products, but I'm not aware of quartz products. But if you do have quartz bench tops, I would think that they would have a high respirable crystalline silica content as well. So would be similar to the engineered stone products. I don't know if that helps, Trevor.
Yeah, well, thank you. It's interesting. So it's a difference in usage then. Yeah.
Yes,
Okay.
yes. I'm not totally familiar with every product we have in Australia for bench tops, but certainly any product that contains more than 1% silica weight for weight would be managed under our new silica regulations and codes of practice. But not being an engineered stone product, it wouldn't be included in the ban.
Thank you.
And then I think there's just one more question, and then I think we can, like I say, if there's any questions after that, I'll collate those after the fact. So from Stephen, we said, thank you, Kelly. Of the small amount of COH, are many of these competent specialists employed by state or territory regulators to drive improvement and change?
Oh, what a good question, Stephen. I wish the answer was yes. We do have some COHs employed by our regulators. I know of, well, in Queensland, because I'm from Queensland, there are at least 2 certified occupational hygienists employed by our regulator. So that's 2. I do know in Victoria there are some certified occupational hygienists employed by regulators. So I would imagine there's a small number of COHs employed by regulators in most of our states and territories, but not enough, I don't think. So there are certainly some COHs in each of our states and territories for both the work health and safety regulator, and we also have separate mining regulators in WA and Queensland, being the big mining states, and they employ some certified occupational hygienists. But certainly, in my opinion, they need to employ more certified occupational hygienists. We need to provide them with more certified occupational hygienists, and they also need to employ occupational physicians because they don't currently do that either. But that's my own personal opinion. Okay.
Well, I think that's it for questions. Yeah, I think it's some of the messages come through now are just people answering each other's questions, which is always lovely to see. So thank you for taking the time out of your afternoon or your evening even, and 5 more minutes on top of that. So like I said, it's been recorded. It'll go up on the BOHS YouTube channel, and you'll see it shared via social media. But if you just check BOHS YouTube channel in the next few hours, if there's anything you missed or anything you want to catch up on. So yeah, one final thank you to you, Kelly, and no doubt we'll hear from you in a future webinar.
Thank you, Lee. Thank you for having me, and thank you all for giving your time to listen to the talk. Enjoy the rest of your day or evening.
Excellent. Take care.
Thank you.